Good afternoon, everybody. Welcome to the last day of the 7th University of Maryland Symposium on Environmental Justice and Health Disparities. My name is Joseph Galarraga. I am a faculty assistant researcher with the Center for Community Engagement, Environmental Justice and Health at UMD School of Public Health. I work with the Maryland Department of Health doing outreach and technical assistance for their environmental public health tracking program. And today I'm joined by Matthew here from NYC Tracking. Matthew, you want to give yourself a brief introduction?
Certainly. Thanks, Joe. Yeah, my name is Matthew Montesano. I'm a data communication specialist. I've been with the New York City Department of Health for about 3 years in the Bureau of Environmental Surveillance and Policy, which hosts the tracking program. And I was actually, some years ago, I was with the Minnesota Department of Health's tracking program as well.
Great, lots of tracking experience. So what we're going to do today is sort of a follow-up. I'm not sure how many people were previously in the other EPHT session, the one that we had just before this, where Dr. Mitchell demonstrated some of the capabilities of our new data portal, the Maryland tracking data portal. But as a follow-up, I think that this is sort of a project to demonstrate how this data can be used to tell stories, to better understand environmental health, better understand disparities and conditions that we see today. And so Matthew and I are both going to be presenting some stories, data stories, using a number of different data visualizations and narrative elements to basically get at some environmental health disparities, better understand health inequity as produced by the environment. So without further ado, I'm going to start here, and I'm going to share my screen. And I also want to note that before we start, that this product that I'm going to be sharing with you is the product of the work of a number of different CEEJH interns and student researchers, and I want to thank all of them for their contributions to completing this project. So here we go. Can everybody see my screen here? Okay, so yeah, as I mentioned, what we're trying to do here is demonstrate the power of environmental surveillance data and what it can really tell us about everyday life and some of the inequities, health disparities that we see in our cities, neighborhoods, towns across the country. We're focusing on Baltimore as a case study using Maryland data. And what we are demonstrating here and what the goal of our project is to show how historical policy related to housing has really created disparities along racial and socioeconomic lines with regards to lead exposure and also lead poisoning. So this is our story. It's housing and lead, redlining, housing discrimination, and environmental health disparities in Baltimore as presented by the CEEJH Center. So as I stated, lead data from Baltimore has the ability to demonstrate a case study on how environmental exposures and subsequently disparities in health flowed from policy decisions. One of the main policy decisions that we're going to be discussing in this story is redlining, which can be understood as a practice in which the Federal Housing Administration rated Black neighborhoods as high risk to prevent people of color from getting mortgages and moving into wealthier, whiter neighborhoods. So this is racist policy that we see that has really led to very entrenched de facto segregation as we see it today. Dating back to the early 1900s, Black Baltimoreans were more likely to be affected by lead poisoning today as a result of policies not only related to the housing, but how lead has been dealt with in lead, mostly in the form of lead paint is the focus of this story, and how this has really produced health disparities that we can see. Another important point is that these housing policies have also had effects on those socioeconomic factors that we see as well. So families who were discriminated against through redlining weren't able to build or pass down generational wealth that is associated with lower risk of lead poisoning exposure, higher education, and income. As I sort of noted at the beginning, this product is, or this work is co-presented by Maryland Environmental Public Health Tracking and the Center for Community Engagement, Environmental Justice and Health, who is putting on the symposium today. So let's dig into what we're talking about with regards to lead, just a little bit of background, because maybe not everybody is familiar with lead and its effects and how and the mechanisms of exposure. So lead is a naturally occurring element that's been commonly used in the world, dating way back to 3000 BC. And in the early 1900s, its common usages were in things like lead paint, which is namely what we're going to be discussing today. Also used in gasoline, toys, etc. So there was understanding that there were some health effects associated with lead, detrimental health effects. And the League of Nations attempted to ban it in 1920. And this was unsuccessful, I think, due to primarily industrial interests. But other countries had some success in banning or at least placing restrictions on lead paint prior to that. So in the United States, though, the use of lead-based paint persisted with support from the painting industry, as it provided, as I said, economic benefits, even though there was knowledge that it's placing risk onto customers. And Baltimore, ultimately, in a lot of ways, Baltimore's is well known, I think, internationally as a health city, public health city, due to Johns Hopkins, and it was the first city to ban lead paint and offer free blood lead level testing at Johns Hopkins. Yet it's become a generational issue due to some other factors in the city that we'll go on to discuss more. So Baltimore has a lot of dilapidated housing stock, and additionally, a lot of older homes. Baltimore is an extremely old city within the context of the United States. So lead is found due to paint, lead, various legacy pollutants. And lead is dangerous because as it enters through the human body through skin absorption, inhalation of particles. So its exposure mechanisms are fairly easy, and particularly because lead affects children in a way, the development of children, and children have lots of hand to mouth behaviors. There's easy ability for children, population who are most vulnerable to the effects of lead, to experience lead poisoning or to be exposed very rapidly. And we can see here, once exposed, it can hinder or stunt cognitive development, reduce fertility, cause seizures, high blood pressure, etc. So as I said, Baltimore has been a city that, in terms of a number of policies, understanding the effects of lead, there has been a trend towards trying to legislate in a way to reduce exposure. But because the fact that most of the housing stock is considerably older, and a number of communities that experience or have high levels of lead have been disinvested in, the lead still exists today in the environment. But we can see that, this sentence here, despite laws from 1993 to 2013, over 65,000 children cumulatively have had significantly high blood levels in the state of Maryland. Okay, so that's a little bit beyond just Baltimore, but across the state. So I think I'm going to kind of move on past some of the policies that we see here. Maryland banning lead use in toys. In 1971, the lead-based paint poisoning prevention act was passed to once again try to reduce the amount of lead that's in the environment. But I really want to talk about how lead has differentially affected populations within Baltimore, because as I said, there's have lead permeated through the environment through a number of mechanisms, largely through lead paint, but also others. And because of that, the fact that at one point in time, it was so thorough through the environment. We still see exposures today, mostly due to the fact of how certain areas of the cities have been disinvested in, as I mentioned. And I think that a lot of this, we have to really look back at policies that have triggered that disinvestment. And that's where we're going to get into redlining and segregation and things like that. So overall, across the country, Black children are associated with higher blood lead levels, independent of age or socioeconomic status. So we can see that this is really an issue that's along racial lines. It's not just a class issue. This is definitively a racial issue. And so how does that necessarily come to pass? We see that there were various lead paint bans that happened, but people, despite understanding the fact that this is indeed a hazard, weren't really collecting the health data on that until later on. So this graphic that we see here, this is data that comes from the Baltimore City Health Department. And what I want to show here is that here along this side, we see the percent of tested children ages 0 to 6 with lead poisoning in the city. And each one of these dots represents a different community statistical area. And I think a good way to think of a community statistical area is either a neighborhood or a group of neighborhoods. And along here, we see the percentage of Black or African American residents within that community statistical area. So here we see this, these are all neighborhoods that are 0 to 20% Black or African American. And as we get to further along the right side here, these are communities that are 80 to 100% African American. And based on the data that was collected in 2017 regarding children, percent of children that had lead poisoning, elevated blood lead levels, we can see that the communities that experienced lead poisoning, they were all communities that were 80 to 100% African American. And what I want to also demonstrate here is a similar trend, but instead of having children that the percent of children that tested positive for elevated blood lead levels, we have the average annual violations per 10,000 households. So these are lead paint violations, and the similar along the x-axis here. But instead of breaking it up, 0 to 20, we have 0 to 25%. So we can see that once again, the majority of lead paint violations, or the most egregious amounts of lead paint violations, occurred in communities or community statistical areas that were 75% or more African American. So even though I did mention that this health data wasn't collected robustly until much later on, despite the various bans, we did see that a report from 1942 showed that lead poisoning morbidity rates were 5 times higher in Black children compared to white children. And as I said, when we start to get this more robust data collection in the 1960s, the City Health Department revealed that 90% of all lead poisoning cases occurred in Black children. And this is where we're going to start digging into really what the conditions are that produce this. So multiple variables in addition to race, such as income and quality of housing, are associated with exposure to lead. We can see a number of different sources concluded that differences between the conditions of homes and the subjection to lead contaminated housing and dust play a role in the disproportionate blood lead levels in Black children. So I think really how is it such that the majority of Black children are being exposed to these conditions? And it's really, I think, a big correlation with segregation, and segregation specifically due to redlining. So redlining was the denying of communities of color or economically disadvantaged communities access to credit, and has led to decreased owner occupation and housing prices in red line neighborhoods. So these effects serve as obstacles to those in red line neighborhoods to build wealth and make them more susceptible to living in homes with dangerous lead levels by preventing them from moving away from older neighborhoods or obtaining loans for home renovation. So once again, just having to live in older housing stock, and housing stock that maybe hasn't undergone a lead abatement, hasn't gone through processes to try to remove lead throughout, and this lead dust, lead paint, etc. And according to the MDE, Maryland Department of Environment, this lead-based paint and lead-contaminated dust is the primary source of lead poisoning in US children. So to demonstrate this, I think we have a number of case studies that I want to show you. Various of these CSAs or neighborhoods. So the highest percentage of lead poisoning that we found through this Baltimore City data set that we used was in Midway Coldstream. And this is a community that has a 95.1% Black population. So this pie chart is a breakdown of the entire city that we can see. So Baltimore is 62.8% African American, 30% white, and then Asian. Some other races, 2 or more races, make up significantly smaller parts of this pie chart. And then when we look at Midway Coldstream and the racial demographics that we see here, this is, you can see it's a 95% African American, Black or African American community. And additionally, this neighborhood, due to in this 2017 data, experienced a higher annual lead paint violations than the average in Baltimore City. That was 9.8, so 36 compared to 9.8. Additionally, you can see that there's a low median household income and a hardship index of 72. So the hardship index is a factor or an index that's created of other measures of deprivation to generally demonstrate some of the barriers that people in this neighborhood might face. So I'm going to scroll down here to this map. This map was put together by a number of the CEEJH interns, as I mentioned. So these points that we see on the map, these are all of the lead paint violations. And this is for the city as a whole. So we can see that across the city, we have lead paint violations, a lot in West Baltimore, East Baltimore, some in the north, and some in the south as well. And there's a few things that I want to kind of show along with these lead paint violations. So these are areas that have a certain amount of lead, properties that have a certain amount of lead. So this first thing that we're looking at here, these shaded areas are the various community statistical areas. And I want to pull up the legend. Oh, I'm having trouble finding the legend, but I can explain what we're seeing here. So the areas that are darker are areas that have higher levels of poverty. So you can see that this is patterned, where we see the more more lead paint violations in the darker areas where there's more poverty. And I also want to show this with that redlining data. So the Homeowners Loan Corporation basically rated various areas throughout the city as desirable or undesirable for investment. And you'll see the areas that are in red are the areas that were redlined. Essentially, these were the areas where African Americans and also Jewish populations were allowed to live, whereas the places we will see in green received a score of A, and those are the wealthier white neighborhoods. Blue, everything that's in blue was given a B, and C is in yellow. So as we change the map here, and we can zoom in, once again, with the exception of this area here in Northwest Baltimore, the majority of lead paint, and some up here in the Northeast, the majority of lead paint violations occur in areas that were rated a D or a C. And I also want to demonstrate that with that blood lead level data, or the elevated blood lead data that we have as well, which is sparse, but even still, we can see the concentration between, and this is something that you would obviously think that if there's the ability to have more exposure to lead, that's where you're going to see areas with higher blood lead levels. So I'm going to now zoom in on that neighborhood of Midway Coldstream and try to show as well the cases here. So let's zoom out a tiny bit and see if we can't find those points. We see this is a neighborhood with the points. The area that has the most poverty around here, the areas with the darker levels of poverty compared to the north here, we see are the areas that have more lead paint violations. I'm also going to show this with the redlining grades here as well. So here we do see an area that has some lead paint violations in an area that was green. But I think what's important to note here is that while this is an area that at one point was rated as a desirable area for people to live, we see now that if we're going to compare this to the Black or African American population, that this is now due to processes of white flight, people fleeing or wealthier white people fleeing towards the suburbs, towards other areas. This is now a majority African American neighborhood, as we saw. So I'm going to move on to another one of our case studies, which is the southeastern community. This is an area that is fairly industrial at this point, but it's also on the east side of the city. And similarly, is more of a has a similar socioeconomic profile, but is a whiter community comparatively compared to a Midway Coldstream. So we see that it's a 55% white compared to Midway Coldstream, which was at 95% African American. So on this map here, similarly, we can see that mapping the population of Black or African American. I'm going to zoom out for context so we can see that this is essentially a white neighborhood here, and very, very few lead paint violations. And this area, as redlined previously, a lot of it was actually not even included in the redlining map. And we can see that we have a red line area over here. We can see that we have some areas that were rated B and C as well. But the areas where the lead paint violations are in the redlined areas and the areas that we see having a lower, a lower grade. And this was an area that had 0 lead poisoning cases. And so the final area that we want to show is Cherry Hill, which is South Baltimore neighborhood, high African American population, a similar demographic profile. But yet this was just an area that during the time when lead paint was widely being used was not an area where a lot of people lived. It was not included on the redlining map. And so we can also see here that through this map, we have very little places that have lead paint violations, just because the housing stock that was here was constructed, or the patterning of people living in this community was prior to a lot of this proliferation of lead paint throughout. As we can see when I turn on the redlining grades, most of this neighborhood, or all of this neighborhood, as we can see, was not included in that. So I do have some timelines here. I'm aware that we're coming up on 1:30, and I want to make sure that Matthew has a chance to present all of his products as well. But we will be making a link to this publicly available afterwards. We have timelines here that describe how lead was permitted, essentially permissible through use, starting up into the early 1900s, as well as the patterning of where people lived in the city. And I think what's really important to note in this timeline is that despite the legislation that we have, and a lot of really good work that has been done by Maryland Department of Health, Baltimore City Health Department, there still is some work to be done. So I think that's really kind of the point of this timeline. But we can see that as time has gone on, there have been much more and more policies that have gone towards trying to make sure that children throughout the state are getting tested, and particularly making sure that communities who maybe don't have as much access to healthcare facilities, et cetera, trying to come up with innovative ways to reach those communities. And additionally, we have a timeline on here that describes processes of redlining and housing discrimination throughout Baltimore. And we can also see that, coming up until 2012, we have through institutions like banks, still see discrimination in the way that loans for housing by Wells Fargo are being distributed throughout communities. You can see that Wells Fargo had the largest number of foreclosures in the city, 4 times the rate of foreclosure in Black communities than in white communities. So unfair loans being targeted to those communities. Additionally, I want to highlight some of the work that's being done, because it'd be remiss to not highlight the fact that there are a lot of groups, a lot of agencies, state agencies, local Baltimore agencies doing work to really come up with innovative ways to not only offer support to people, but to really reach people where they are. But I do think that one of the things that should be emphasized here is that this really isn't a problem that stems back to the early 1900s in the city, and even before that, when we look at policies that precede that at the federal and state level that have basically cemented racism as a structure within our society. And therefore, really to equitably solve these issues, a perspective that really takes that into mind is essential. So I'm going to stop sharing here. I think that it was ambitious to try to get across through this in half an hour, but I am going to hand it over now to Matthew. And at the end, we'll make sure that we have some time for questions in case anybody wants to discuss what we're seeing. So thank you very much. And over to you, Matthew.
All right. Thanks so much, Joe. That was such a thorough run through. I really like everything, all of the information that you have in there. I'm going to share my whole screen because I'm going to toggle back and forth a little bit between some slides and between a web browser. Before I get going, I'm just going to say thanks again, Joe, for the invitation. It's really a pleasure to be at this symposium, and I'm grateful to those of you in this session for joining. Again, my name is Matthew Montesano, and I'm a data communications specialist at the New York City Department of Health. And as Joe mentioned, we're part of the CDC's Environmental Public Health Tracking Network, which was established some 20 years ago or so to connect data on the environment to data on health. So this network is federally funded. It's a network of states and cities. And we're tasked with gathering and analyzing data on environments and health and publishing that data on the internet, right? So this overlap of environment data and health data is really where this network of environmental public health tracking lives. So I think this really begs it begs a big picture question of what is the environment? What counts as environmental and what is within the scope of our analysis? And the environment, of course, is chemicals in the air, ground, and water, sure, and it's also weather and the climate. But it's more than that, right? It's everything outside the body, everything that surrounds us. And that means that it's the built environment. Joe highlighted a bunch of housing issues, obviously. And it's also our social environment, the social, political, and economic realities that play a role in determining our health. So as we've been tracking and analyzing the connections between environments and health, it's very hard to ignore this bigger picture, this incredible extent to which our social context determines what parts of the built and natural environments we get exposed to. And again, thinking big picture, public health is a profession that tries to look upstream, right? From what's happening to why is it happening? And obviously, like the canonical story here is of Jon Snow removing the Broad Street pump handle because that was the pump with the contaminated water that was making people sick. So moving upstream from people getting sick to preventing people from using the pump with the contaminated water. So I think that looking upstream is about this fundamental shift from what's happening to why is it happening. And thinking about this in the context of environmental justice specifically, I think we're in the midst of an interesting shift in focus in the field of public health broadly. When I started working in public health 10 or 15 years ago, it was fairly common to see analyses suggesting that race is a risk factor for a certain health outcome. That's the what, disparities by race. Though I should note that there are many problematic things with this comment that I thought was incredibly common, that race is a risk factor. Since then, I think it's much more common to see analyses that show that racism is the risk factor. And that's the why, describing the system that produces racial disparities, shifting from the what to the why and looking upstream. So an example here, right? The what might be looking at youth asthma and noting that there are incredible disparities among different racial groups. The why would be noting that these disparities are due to racism, due to current and historical policies and environments that we can improve, we can affect. This is not just the situation that we have, it's a situation that we can affect. We can figure out why it's happening, what's causing it, and we can change those. So I think that environmental health is a field that's really uniquely poised to help drive this type of inquiry and describe these connections. And I'm going to go into how we've been doing that in New York City. I'm going to take you over to one of our data stories that we published this past year on health, housing, and history. And I will also drop this URL into the chat here. I'm not going to go through and read this word for word. I'm going to take you through some of the large beats, but I just sent this URL to the chat so you can follow through on your own. You can, kind of linger on the items that you're really interested in and read the items that you're interested in as I guide through this. I think this has a lot of information. We try to present it as clearly and simply as possible. So that means, using interaction where it's convenient. And that's an important part of our work here that I'm going to touch on later and really focus on not just what we're communicating, but how we're communicating it. So for starters, and as Joe mentioned very well, housing is a really crucial way that environments affect health. Homes can affect health in a lot of different ways, right? Like a healthy home is a well-maintained home, and an unhealthy home can lead to a real whole host of health outcomes. And in our tracking program in New York City, we've got access to really incredible data that we'll get to on how housing can affect health. But again, looking upstream, we really see that New York City's residential patterns have been racial throughout its history, specifically throughout its colonial history. Racism and racist structures have always determined who lives where. Wall Street in New York City, which is a street that many people are familiar with, took its name from a wall. And in 1661, when Black people petitioned the burgeoning colony for land in the area, they were given land outside of the wall, outside of the city proper, outside of the protection, if you will, or defense or barrier that the colonists had erected to keep natives out. So throughout, this is just one example, but throughout the history of New York City, many different practices have shaped the residential patterns and the racial and residential patterns specifically. One of the ways that we see this in the sort of modern era and in a very powerful way is with redlining. And Joe went through redlining in quite a bit of depth, and we've got an overview here. We also have in this piece a link to another piece that just focuses on redlining as its own. And I sort of assume that many people here are familiar with redlining, but for those of you who are not, again, feel free to explore this and the related document that's linked. But in short, the federal government was subsidizing loans to buy homes or refinance mortgages to help keep people in their homes during the Great Depression and to guide the idea of a safe investment. It created maps of some 250 cities across the country and sort of cataloging and assessing these neighborhoods by brutally racist standards. So this is a map of how New York City's residential neighborhoods were assessed. And you can see, you know, if I sort of toggle off, you can see that just a tiny sliver of neighborhoods were considered best, and not many more were considered still desirable. And really broad swaths of land here, of residential area, of people's homes were classified as definitely declining, or hazardous, again, based on very racist criteria. I think that about 3/4 of the residential area in New York City was put into these bottom two tiers. And so with the redlining maps established, a few things happened as a result. So loans were only approved to buy property in the top two tiers, and people of color were largely locked out of home buying opportunities as banks used these maps to guide loans and sort of reinforced racist real estate practices like blockbusting, contract selling, and racially restrictive covenants, which you can read more about by clicking on these fun little green pills over here. These are practices that continue today, even though redlining has been specifically outlawed since the middle of the 20th century. But the big picture here is that this resulted in a significant shift of residential demographics and of wealth. Again, this is a great talk because Joe sort of hit a lot of the beats that I was going to hit, so I can just reinforce his points. But homeownership is a valuable way to accrue wealth in a multi-generational way. But this system that was, you know, instituted for a few decades essentially locked people of color out of this opportunity and subsidized white suburban flight. So this was essentially a transfer of federal resources through homeownership loans to white people. And through real estate practices, people of color were steered toward these C and D ranked neighborhoods, but prevented from getting loans to purchase, right? So this is what transfers us into healthy housing. The establishment of a rental class, a class of absentee landlords. And what this results in is disinvestment, right? This process of removing or not investing, removing resources or not investing resources in these specific neighborhoods. So this sets the stage. This really gets to the way, the multi-generational way that this racist policy of redlining affects people's environments, people's housing, and their health. In New York City, the Department of Housing Preservation and Development runs the Housing and Vacancy Survey every 3 years. And from this, we get a wealth of data on housing conditions. So in New York City tracking, we look at 9 indicators of healthy housing problems, and we focus in on the proportion of housing that has 3 or more of these problems or none of them, right? So here we've got the percent of homes with 3 or more healthy housing problems, and these are concentrated in neighborhoods that were aggressively and almost entirely redlined, as opposed to the percentage of homes with no healthy housing problems that is predictably sort of the inverse of that. Those of you who are familiar with New York City health data know that a lot of health maps look like this. A lot of health maps overlap with redlining maps and with poverty maps. These are neighborhoods that are predominantly populated by people of color. So we can also, in this piece, click into these specifics on all of these healthy housing problems. And these individual items are sort of directly associated with specific health outcomes. Cockroaches are an asthma trigger, as are mice and rats. They can also have lead to mental health outcomes. Cracks and holes in the walls are associated with lead poisoning. Water leaks are associated with asthma and some other health outcomes, right? We can go on and on. Broken plaster and peeling paint, heat breakdowns, the need for supplemental heat, the lack of air conditioning, which is a huge risk factor for heat-related stress, and toilet breakdowns. And you can see, again, as I click through these maps, that these are, by and large, really lighting up the same neighborhoods, these same neighborhoods that experience these chronic disinvestment through the segregation that resulted from redlining and this establishment of a class of renters and absentee landlords. So what we're trying to show here is that this legacy of racist housing practice and disinvestment directly leads to these housing conditions and to these healthy housing problems, that there's a big racial disparity in access to healthy housing. And as we go further, we note that this racial disparity is really powerful and that it's racial. Again, Joe hit this point really well, and this is another way that we can reinforce this. When we stratify by income level, we see that this pattern remains, right? So it's not that the race of residents in these neighborhoods is sort of a proxy indicator for poverty. When we look at income, we still see that white and Asian people have higher rates of access to healthy housing than Black and African American and Hispanic and Latino people, suggesting that there is something racial and racist at the root of this, right? That this isn't about who can afford housing in what areas. It's about a system that segregates access to healthy housing. So this is our background, right, on redlining, disinvestment, segregation. This gets into our what, right? Healthy housing, which can affect health in so many ways. And this brings us to our health outcome. I mean, as I mentioned, there are many health outcomes, and we see this so clearly in asthma, especially youth asthma in New York City. This is one of those health conditions where the mechanism is really powerful, the disparity is profound, and the effects of this unjust system are seen so clearly in the data. Asthma is a social justice issue. It's a condition that's clearly exacerbated by depriving people of access to healthy housing, to housing disinvestment, inequality, and this injustice, this system. So here we've got the percent of population that is people of color in New York City neighborhoods and the rate of childhood asthma emergency department visits. And you can see that there's just such a close correlation as I scroll through this fairly lengthy bar chart. Another way of rendering these data is in a scatter plot here. And there's a really, again, this is showing us a really powerful correlation. So I encourage you to look at this on your own time and dive into the depth of some of the data and some of the other resources we offer. Again, I also mentioned that we've got this piece that goes into a little bit further detail on the history of redlining and how redlining connects poverty, race, racism, and health. So feel free to explore that as well. But I'd like to make the point here that this is really just one example of disinvestment or of racist policies. The connection to healthy housing and to health outcomes is really just one way that this affects health. So this piece that we have on housing and this companion piece on redlining, these are not one-offs. These are a part of our series of data stories. And I want to go into a little detail about what we're doing with these and why. We've published some other data stories on how asthma is a social justice issue, on what it means to view violence exposure as a public health problem and to change the frame from a criminal justice angle to a public health angle, and others. And I invite you to explore these on New York City's Environment and Health Data Portal. And our strategy with these is to move from publishing data to communicating it. User research has been a really valuable part of our development of these and our development of our data portal. And when we sit down and we talk to people who use our website or who look up health data in New York City, or who use data for research, for advocacy, or for healthcare, we hear some really interesting things. First, sure, people can generally find and access data, but there's a level of interpretation or knowledge past the data that a lot of people are interested in understanding. They don't just want our data sets, the what of the data value. Rather, they want our knowledge about why things are the way they are, our conclusions, our interpretations. When people are looking up the asthma rate for their neighborhood, they're not really looking up the number. The number doesn't matter. The comparison matters. How does my neighborhood compare to the city as a whole? Where is it high? Where is it low? And why? So that comparison is really the crucial piece of information. That interpretation is the crucial piece of information. What explains the pattern, the distribution in the city? Just making a data set available doesn't communicate that, but it's vital that we communicate that. Secondly, people tell us that they want information to be user-friendly. That's what they say. Those are the words that they use. It's got to be user-friendly. There's a law in web usability research, or a guideline, that people spend 99.9% of their time on the internet, not on your website. So that is where they get their expectations for web content in the web at large. And that means that it's important to stay abreast of contemporary habits and techniques for communicating information, because that's what people are used to reading. And if they don't find that at your site, they might not stay, they might not get that information. So that means if we really want to reach our users to offer them this information, we have to do it thoughtfully. So our data story strategy is rooted in these concepts. First, getting the data out there. Secondly, making sure that we're also providing this level of interpretation. And then third, making sure that we're making it clear. We're using plain language, we're using clear design techniques, and we're using these visual explanations. So, to that rule of web usability, this means that we're designing what we publish according to some more contemporary standards than are often found on public agencies' websites. That doesn't mean that we need to hire an expensive web development firm. It just means that we need to look around at usability standards and guidelines, design with care, design based on feedback from our users. And it means that we need to write with care too. We use a conversational tone. We write as we, and we write to you. We use plain language as much as we can, but we don't shy away from introducing and explaining more complex topics. And this is really how we take this information and we make the data easier to access, easier to understand, and easier to use. And I think this is hugely important. I'm very passionate about this. I'm keeping an eye on the clock, but I could talk about this for another few hours if you let me. But what we're doing as a government agency is working for the public. We work with public funds, we create public knowledge, and we are doing our constituents, our neighbors, our communities a disservice if we do not share that knowledge in useful ways, in understandable, legible ways. And I think this is a really important component of information equity, breaking down barriers to accessing and understanding information, especially government information. We want to take insider knowledge that's often buried in PDF reports on some unnavigable government website, and we want to work on this issue by making the information clear and easy to understand. I think that there can be incredible value in stating plainly what we know. we're the health department. We are an authoritative source on some of this information. If we can say and justify some really powerful statements that racism affects health and how unjust laws, policies, and practices affect health, then other people can use that, they can cite that, they can really dig into that and say, the government says this. And with that, I think that it can bring us another step toward working together to unbuild some of these very harmful structures in our society. And that's why we create these data stories about these topics in the ways that we do. Thank you for your time. I'm going to turn things back over to Joe, who I think is going to open the floor for questions. And anyone can feel free to grab my email address if you'd like to chat further afterward.
All right. Thank you so much, Matthew. That I think that you some of the points that you're making there at the end is exactly I think what we're trying to accomplish through doing outreach and communications for the Maryland Tracking Program, and hopefully what we try to accomplish with this conference as well, with the symposium. One of the things that I really appreciate about the symposium is the variety of people that are here, because so often I think that we have, especially when you're talking about environmental science, environmental health, and the theme that's really been brought up over and over again over this weekend and on Thursday is the importance of having communities at the table when making decisions. And I think that really the goal of these programs of tracking is to provide tools for people who have their lived experiences, who come and know these things to be evident. But when we as Maryland Tracking or NYC Tracking can say, yep, here we have this map, we have this product, we can definitively say, like you said, that racism is affecting public health, that has the ability to bolster the community voice, and we really should be allowing people to lead with those voices and provide support that way. So I really want to thank you for coming today and speaking those words. And so, along those lines, I want to open up the floor to questions for Matthew and myself. If anybody has any questions, you can, say them aloud, put them in the chat. I see that we have a question in the chat already from Kathy that's asking, has anyone been looking at lead in local school parks, rec or church rubberized playground, the tire crumb that's filled in for fields, lead in those black or synthetically colored plastic surfaces? And then there's a link. I'm gonna open the link here, and I'm not sure exactly. I see DCPS lead on playgrounds. So this is within DC. Okay, thank you for sharing this resource, Tireless DC. Yeah, I think that that's something that is important to note, certainly, is that, one of the things and one of the noted limitations of the story that I presented on lead and redlining was really, it was talking about, housing, and how housing and housing conditions and housing policy have really created differential exposure and differential health outcomes for people living in Baltimore. But it's not the only mechanism that's producing health disparities or exposing children to lead. And I think that that's something that when we were coming up with this story, realizing that we had to narrow the focus a bit, because certainly there's a lot of different exposures and routes for exposure. And unfortunately, this seems like a very big oversight in the fact that this is a material that's being used in, for children's, in the same way that we know back in the 40s that we're going to ban lead in children's toys of a certain amount, and this just seems like a big oversight. So I want to thank you for bringing that up and bringing that to the attention. And I think that that's for anybody in here that's listening and maybe has children or is and bringing them to playgrounds, maybe something to consider when you're taking your child to the playground. So thanks for bringing that up, Kathy. Okay, I see a question from Veronica that says, as in the earlier session, my question is, how can we use this information to inform practices, policies, regulations, and laws to ensure that there is consideration of health in all policies? We know what created these neighborhoods and conditions. How can we ensure that we can ensure sustainable communities? I'm curious, Matthew, if you want to take that first, I can follow up maybe.
Yeah, I think that's a great question. I think that is perhaps the $1 million question. I think that in public health, we often are faced with a situation where we know quite generally and often quite specifically what needs to happen. We know that inequality affects health. We know that poverty affects health. And right, so that's sort of a bigger picture question or a bigger picture approach to your question, but like, how do we address that? How do we ensure that resources are going to those who need it the most? How do we make sure that politicians are paying attention to what we say? I don't have an answer for that, but I know that the coworkers that I work with see this with great frustration and also wonder how we can do more, because what's necessary for a society that values health has to be built by so much more, as you point out with this phrase, health in all policies, has to be built by so many more people than those in departments of health. I mean, it requires a true population-wide commitment to working together on something. And I think that the past number of years has shown that in the United States, we really struggle with that. So I don't know the answer to your question. And I think that it pains me, and it may pain you, and it may pain other people here.
Yes, thanks, Matthew. I think that that's a good point. And the one thing that I want to echo is that, yes, it takes a diversity of people and a bunch of different stakeholders coming together, I think, to really make this difference. It has to really it's kind of I was very inspired earlier today by the session on the 30th anniversary of the founding of the EJ principles with Vernice Miller Travis and Peggy Shepard and Tom Goldtooth and Charles Lee. And really what I took away from that is like, this was, a bunch of people that felt very isolated maybe due to various experiences with racism and alienation, and also experiencing, the effects of their environment, but coming together and building power. I think that's really an important thing to do. And one thing that I want to note through my experiences, my limited experiences working with CEEJH and Dr. Wilson, is that I think that's something that's been really revelatory for me, is realizing that our policymakers, our legislators, they don't necessarily know a lot of. You think that they would know these things, right? Oh, you're the person who is a policymaker for the state. But the fact is that environmental justice, despite being around, now we're celebrating its 30th year, it's still sort of a topic that is not, hasn't penetrated the mainstream. And I think we're getting there. And I think that that's what we're trying to do here, is educate too. So I think that while we do know the conditions and some of these things that have created the disparities that we see today, I think that it's maybe a little presumptuous sometimes to assume that policymakers are well versed in this. A lot of, you think about maybe who's your state legislator, maybe they have their roots in community organizing, or maybe they were a lawyer previous to this. It doesn't necessarily mean that they have this expertise. And so one of the things that CEEJH is trying to do is try to engage policymakers, trying to make sure that these things that we're showing here, we're demonstrating, are evident to them, and that also their constituents care about it. And I think that that's what it comes back to, is this building of power, and also making sure that that we continue to, I guess, say these things and say them to the right people, and make it be known that these are the issues, these are the sort of solutions that we need, as opposed to maybe a piecemeal solution, etc. And I do think that something else that Matthew said that I want to point out is that we are coming to, it's becoming more evident that these are ways that we're failing. But I think that even us knowing that this is a way that we in our country don't necessarily know how to handle things is becoming more and more part of the conversation. That that yes, we have these conditions that have been produced by these upstream causes, and we really need to try to address those more so than the symptoms, right? You treat it at the cause as opposed to the symptoms. So appreciate that. Very, very good question. And hopefully we were able to offer a little bit of insight there.
Joe, I have a couple additional thoughts based on your comments.
Sure.
Actually, you mentioned that, politicians and other leaders might not know some of this stuff. I think that's totally true. And I also think that, like, traditionally, this field, many others, this touches on what I was talking about earlier, but we're used to producing information for these leaders in these like thick reports, right? Like binders that get distributed at legislative sessions. And I think that as a communication strategy, that's really limited and really bounded. So I mentioned that we were trying to make this, like democratize this information by making it easier to access, easier to understand, easier to use. And I think that makes it more likely too that a politician or a policymaker can skim it and get it. Like that's what we want, right? All of this stuff just needs to be kind of outside of the encyclopedia of information, and into just a much more digestible and transmissible way. So I think that that's a tactic that we can use. I think that another tactic, or another effect of that tactic rather, is giving this information to other advocates and organizers to use as they can, and hoping that what the health department says can give them more traction. I really liked your comments, Joe, after I spoke, and I think that when we do this stuff, we're following in the footsteps of people who've pointed this out. Like you mentioned lived experiences, and there are researchers and organizers and advocates who've been saying this stuff for a long time. And government agencies, I think, are a little bit late to the game in what we say and how we say it, but hopefully like coming into the game can provide the force of what government agencies have. And I think back on my days as an anti-war organizer and as a community organizer, and I think about this phrase, a diversity of tactics in order to get things done. I think that, maybe one answer to using this information to inform practices, policies, regulations, and laws is with a diversity of tactics, making information that advocates, organizers, and troublemakers can use, making information that policymakers can use, and supporting stuff that supports like incremental legislative change, and supporting movements that are just seeking to really rebuild things a whole lot faster. I think that embracing a diversity of tactics and solidarity as we work towards health in all policies and a society that values the health of the people in it, I think that's a good way to go.
Agreed. Thank you, Matthew. And thank you, Veronica, for an excellent question. We have about 5 minutes left. I wanted to see if anybody else has any additional questions or any additional thoughts based on some of the questions and our responses or anything like that. I'm welcoming any and all of that. So. Okay, well, in if there's nothing else, we can wrap up 5 minutes early. I want to thank you all for being here. I want to thank Matthew for joining us today, bringing a different, perspective. A lot of the focus of the UMD-EJ symposium is on DMV area, environmental justice and talking about health disparities, but it's good to see the New York City perspective, and ultimately it's not that far away, and we're neighbors basically. So I want to thank you for taking some time today to share what you all have been working on, and also really expounding upon the importance of like communicating things in a way that people can use. So that is I think is super important, and something that we all, or people in my position and it needs to do better. So thank you so much, and take care, everybody. We have concurrent sessions, one more round of concurrent sessions, and then in the afternoon we have a final panel on the White House Environmental Justice Advisory Council and President Biden's executive order on climate change. So thanks so much, and we'll talk later.